I'm a student of the brain. I've loved the brain since I was in high school. I've been amazed by how mysterious and how elegant it is. We got 100 billion neurons in our brain. That's more than the stars in the Milky Way. We're constantly trying to chart new territories in the brain, constantly trying to map the brain. And as we've been mapping it, we have found entirely new areas of the brain that we didn't know existed even a few years ago. It'd be as if we were traveling Earth and suddenly came upon new civilizations with new cultures, new languages, new ways of life. That's how amazing the brain is and how much we're continuing to learn about it. But we got a lot more work to do, which is why we're having this session today. I'm a neurosurgeon, so I focus on fixing the brain when it's broken. What we really want to do is to better understand the brain, better train the brain, and better see the brain. So with that, let me introduce you to Mary Lou Jepson, who's CEO and founder of Open Water. She's done many, many things in her past, which you'll hear about soon, and we'll be talking about better seeing the brain. Richard Castelli is a professor of neurology at the Mayo Clinic, and he's going to teach us more about how we can better understand the brain, and one of its most important functions, I'd say, memory. And Adam Gazzelli, a friend of mine, who is a professor of neurology, physiology, and psychiatry, we could all use that, at UCSF. He's also founder of Neuroscape, and he's gonna better teach us how to train the brain and make it better. So thanks to all of you. Welcome. Mary, let me start with you. Ladies first. You got into this area for a very particular reason, a personal reason.
Sure.
Can you tell us a little bit about that?
Sure. In 1995, I was a graduate student in physics at Brown University. And I had the symptoms of full-blown AIDS, but I was HIV negative, and nobody could figure out what I had. I was sleeping 20 hours a day. I was living in a wheelchair. My body was full of a rainbow color of sores, and it affected my intellect. I couldn't even think through the simplest of problems. So I faced facts, and I filled out the paperwork to drop out of grad school, and then somebody sprung for the cost of an MRI. They found my brain tumor. I had it surgically removed. I got better. I finished my PhD 6 months later, and I co-founded my first startup and went on to work. But it's been never far from my mind because I take pills every day for the last 21 years to live. So I've been thinking for a long time, how could I make a low-cost MRI system? And I've just figured out how to do it, so I left Facebook to start a new company to lower the cost of MRI by 1,000-fold, to put it into a wearable in a consumer electronics form.
You're talking about a low-cost portable MRI scanner,
yes,
making it more available, making testing more available all over the world. Before, I'm going to talk specifically about that technology, but after that time in grad school up till now, what were the various places that you went, companies that you worked for? How did you sort of start executing on that vision?
Oh, I didn't. I needed health care because it was 1995 and I was an American. So I made money. So I co-founded 3 startups. This is my 4th. I was an executive at Intel, an executive at Google. I worked for Sanjay Gupta, helped start the Moonshot Group, and most recently I've been running advanced VR and AR development at Facebook and Oculus. And I was a professor at MIT for a while. I did a lot of things.
You've done a few things. We'll get back to the specific technology here with regard to MRI in a second. Dr. Castelli, why did you decide to go into neurology?
Oh boy, well, just for the very adolescent fantasy thing that I thought the brain was fascinating and I wanted to understand the material basis of mind. When I went to medical school, actually, there were no physicians in my family, and I actually had never even heard of a neurologist. And during my schooling, I met Eric Kandel, who of course is a Nobel laureate in neuroscience, and other such notables, and found out, wow, you could actually specialize in a branch of medicine that deals with the brain. I know that sounds very naive, but I was coming from a very naive place. So really it was quite that simple.
You're a professor of neurology at the Mayo Clinic, and one of the big areas for you is Alzheimer's disease. We're going to talk a fair amount about that today, but let me just start with a simple question. There is, I think there are about 5 million people in the United States with Alzheimer's. Over the next 35 years or so, that number is expected to triple. There is a gene that makes you at greater risk for Alzheimer's, and the estimate is that 20 to 25% of people have this gene. We'll get into all the specifics around this, but let me just ask this. Should we get tested for this gene? The average person, not necessarily any risk factors or any problems right now, should they get tested?
So my personal opinion, short answer is no. The longer answer, it really depends upon the context in which it's occurring. The gene we're talking about, apolipoprotein E epsilon 4, which, as you say, is present in about 20 to 25% of people living in North America. It varies somewhat worldwide. It's lower in certain Asian countries and Mediterranean region as well. And Alzheimer's incidence rates parallel that. It doesn't influence the therapeutic options that we have for patients. And because the form of Alzheimer's that it is most deterministic for is the form that strikes us when we're older, say 75 to 85, that age range, and of course there's variability, but roughly speaking, it's not the sort of thing wherein if a patient is tested, let's say who's 78 years old, well, they have that E4 gene, should we test their children to find out? The reason you do genetic testing is so that you can do some sort of intervention. Now, if you happen to have a gene that's going to give you a disease that disables you when you're 48 years old, you might want to influence what your children do in terms of should they become a neurosurgeon, spending half their life becoming that just to have a couple of years productivity after that? Should they marry, have children, pass this on?
Not quite that bad. Yes, I get the point.
But with ApoE4, I mean, what are you going to do? Tell people not to have kids because they might develop Alzheimer's when they're 75 years old?
All right, quick reaction, Mary Lee. Would you get tested?
Of course. I have been. I don't
course.
actually, I mean, I did 23andMe. Is it in that? I don't, sure. Why wouldn't you want to know what's going to happen to you?
Well, obviously different people handle it differently. I wouldn't want to judge everybody by your standard. Not everybody's going to necessarily handle it the same way you would. But if you do surveys of people, you will find most people like yourself do want to be tested. They are interested in finding out. If you ask them other hard questions like, if you found out that you were at very high risk for Alzheimer's, would you seriously consider suicide? And so people answering that on an internet survey, 11% of them said, yes, I would.
You might go into trying to help solve it. Spend your good years trying to protect yourself. You know, you might actually get more people working on it.
Might it inspire even more innovation? Quick show of hands, how many people would get tested if you could get tested for this?
Not everyone.
Interesting. Okay. To be continued. We'll come back to that. Adam, I want to get to you, though. You're a professor of neurology, physiology, psychiatry. You founded this company now. What is behind this for you? What was sort of driving the thought process?
Yeah, as a neurologist, we have a very small collection of tools that we employ to help people's brains when they're failing. And this is true across all of neurology and psychiatry. If cognition and the mind is affected, we have all of these very fundamental problems in our system right now that most of us are aware of. And I'm just going to go through them real quick. We don't really have great assessments. The amazing tools that we use in the laboratory to understand the brain don't really make its way into the clinic frequently. And so if you go to a doctor, we often don't actually know what's wrong with your brain that brings you there. And then we also don't have very targeted treatments. So we've relied on small molecules for 50 years and haven't really had a major win on a tool that can improve some deficit, let's say it's depression, anxiety, or attention problem or a memory problem, without having side effects, because they're not really acting on the neural network in the brain. And so we have to increase the doses to very high levels to get effects, and then we get pretty much just as many side effects as effects. And the other big problem is that they're non-personalized. So we base our prescriptive advice on large population studies that really ignore all those individual differences of the people in the studies. And then the last problem is that they're non-adaptive open-loop systems. You take a drug, you go home, you subjectively monitor your effects and side effects, go back to your doctor, and then they go up or down a little bit, right? This is the art of medicine. And it's not really an effective way to change something as complex as the human brain. So I was just really frustrated that, it's 2016, and this was 8 years ago when I sort of peaked at my level of frustration and wanted to do something about it. And living in San Francisco, where we're surrounded by technology, and I mean non-invasive consumer technology, often in the entertainment and media and communication domain, which is great, but can we take that, reimagine those tools, and help create a new category of medicine, new assessments that are more real world and have advantages that overcome these deficits I just described.
You know, it's so interesting. I don't know if Sir Andrew Whitty is here, but I remember he went from GSK. He once said to me, I thought something very interesting. He basically said, had we sort of really discovered or understood electricity before we understood chemistry, most of our interventions medically would probably be electrically based as opposed to chemically based. Which I thought was interesting. Electroceuticals is the field actually putting in micro implants to stimulate electrically versus using chemicals. You're talking about something different, but sort of the same concept, right? Not using drugs.
The idea is that experience is the gateway to our brain's plasticity, right? This ability of our brain to modify itself at every level, its structure, its chemistry, its function, all in response to experience, right? It's the entire basis of learning. The idea that experience leads to plasticity is very clear to us, right? Even witnessing a single tragic event can detrimentally impact your brain, right? We call that PTSD, post-traumatic stress disorder. So the idea is that if we create an interactive experience that's very targeted and also adaptive, so it's constantly learning where you are at that moment and challenging you appropriately, this would be a much more targeted way to activate a brain network than we have ever accomplished with a molecule. And then through this adaptivity, what we call a closed loop, we put continuous pressure on that network to change it over time. That's the idea. And then you can overlay things. Like we actually do electrical stimulation, to your point, through the scalp, wearing caps, to help stimulate even more plasticity. And you can even think about a drug, now not in the context of having a silo around it that you expect it to cure something as complex as like depression or an attention deficit, but in the context of a game, maybe you could have a lower dose, lower side effects, and then there'll be an interaction between how your brain is activated selectively by the game experience and how the drug might then not be relied on solely but can just activate the system.
What do you call this? You don't call it video games. You call it brain training? What is
I mean, we think of it as a digital medicine.
Digital medicine.
And we are trying to move it out of that domain of brain game and brain training into real clinical practice, like going right through the FDA pathway as if it was a drug or a device.
Dr. Castelli, I want to get your reaction to this in a second, but I'm going to tell you, we're going to open it up for questions as well. There's a couple of microphones floating around. If you have a question, raise your hand, and I'll find you, and just state your name as well so we know who you are. But feel free to ask a question to the panel. But Dr. Castelli, you come from, since your just adolescent sort of aspiration of yours to be a neurologist and treat these disorders of the brain the way that you do. When you hear about digital medicine potentially being the future, what are your first reactions?
I think it's a very exciting new avenue. The initial applications, I would think, would be aimed at more static types of processes like head injury, stroke. The problem with a disease like Alzheimer's is it's progressive, it's degenerative. Whatever progress you make today is unfortunately not going to last unless something really unexpected happens that we start regenerating circuits, but so far nothing has ever been shown to do that, so I'm not expecting that. So I think it's a very exciting new avenue.
Mary Lou, I mean, you mentioned you take lots of medicines. You have to take lots of medicines because of the brain tumor, the pituitary tumor that you had. When you hear about digital medicine instead of taking these pills, what are your thoughts?
It's magical thinking to think that part of my brain is going to grow back. They're very simple chemicals. It's not really medication. I'm just...
You're replacing things. Yeah.
I'm replacing things that part of my brain. But by digital... Most digital electronics is actually analog at the root, so I don't really know what the word means, which is very strange because I'm an electrical engineer, but I actually don't know what it means. Can you explain what you mean by digital medicine?
Yeah, so basically any interactivity with some type of consumer-grade platform. So in our case, video games, to get more specific.
Oh, so using tech? Yeah, sure,
tech.
Of course.
Well, we're going to show some of this as well, I should point out. So if this is seeming a little bit vague, Adam's actually going to show what an example, at least, of one of these games. I've played it myself. Did pretty well.
Yeah,
I
you did.
say so myself.
See how you did today?
Yeah, we'll see how it goes. I order MRI scans all the time, Mary Lou, on patients. We're looking for brain tumors, we're looking for a herniated disc, all sorts of different things.
Sure.
It involves a big structure, putting people in essentially this tube that is a magnet that provides really high quality images, allows us to do our jobs better. You talk about wanting to, again, make it portable, cheaper, making it much more available. Is that possible? What is the secret sauce here?
It enables continuous monitoring. But the secret sauce is actually, I had an insight, a part of physics that's been known for 50 years that's been ignored. That has to do with holography, like true holography, the thing that won the Nobel Prize.
Why did you grimace a little bit when you said holography? Is it because holograms have sort of gotten a little bit of a bad rap, or?
Oh, that's like Tupac on stage in Las Vegas, or the marketing terms
Gotcha,
for virtual reality and augmented reality. I mean recording the amplitude and the phase of light, phase being waves. And what holography does is create a system that records the standing waves of light if you create the right system. And a standing wave is a lot like when you pluck a guitar string and you can see the notes. And if you can record the standing waves, you can record all of the light at every angle that transmits through or reflects off of an object, including the scattering of our bodies. And then the really big insight is that you can then compute an inversion of that. Our bodies scatter near-infrared benign light. It's transparent to light. That's why heat works. Those heat lamps last night at dinner, that's why they go through, they warmed you up. At much lower levels, at lower levels than you experience walking outside during the day, we can penetrate our entire bodies with near-infrared light, but usually you only take the first light through, the 1% that doesn't get scattered, and that gives you a low-resolution image. It's still expensive, but using holography, you can invert the scattering and look then for the absorption of blood, or oxy-deoxy as it's called, which is what functional magnetic resonance imaging does, meaning where your brain uses oxygen versus not using oxygen, which is exactly what fMRI does, the multi-million-dollar machines. But putting that into basically a liquid crystal display illuminated with invisible light on the lining, the inside lining of a ski hat or a bandage, to allow us to bring the cost of a multi-million-dollar machine that takes up a quarter of this large room and costs $1 million a year of upkeep into a consumer electronics wearable. I had the head of a large European country say, the moment I have this ski hat ready, he's issuing it to every patient in his country with clinical depression for continuous monitoring of clinical depression. Because people don't kill themselves when they're at rock bottom. They kill themselves as they're coming out, often in a nonlinear, erratic way. 1 million people commit suicide every year globally, for example.
How good is the quality of the scans, and what can you see using the techniques that you described with light versus, the magnetic resonance of an MRI?
What we've shown in the lab so far is we can get higher resolution, and we can get blood and perhaps even neurons directly, non-invasively for the first time. Because when a voltage goes down a neuron, it roughens the membrane of a neuron, and that scatters light. So since we've neutralized the scattering of the body, we can look for the differential scattering of the neurons. Scattering, like if I took my glasses and rubbed them with sandpaper, I couldn't see through them. But when the voltage of that membrane or of the neuron goes back down to zero, it smooths out. And so we can look for the heartbeat of these neurons and perhaps directly image the neurons, which is far better than anything we have. So what I'm doing with this company is spending the next 6 to 12 months defining what we can measure, what depth, what resolution, and what architectures work best. I was speaking with a group last week saying, can you go for glucose? And I thought glucose is well covered, maybe it's not. We're looking for what we can image optically, because I think, it's really a truly unconventional approach. But when you look at what the big iron medical imaging companies are coming up with, their next innovation in MRI resolution is 7 years from now. And my bigger goal is to put this on the track of consumer electronics innovation, where you can get a new cell phone every 6 months. Why not a new? Let's start that innovation cycle with the underutilized fab capacity of Asia.
We got a couple of minutes left. I want to make sure if there's any questions that we can get to them. Anybody has anything? This is complicated stuff, so don't feel shy if you want to ask something. Dr. Castelli, there's this. Besides, let's say you have the sort of good imaging that comes about from portable MRI scanning, like Mary Lou is describing. What about the value of that sort of almost around-the-clock testing? From a clinician standpoint, is it valuable to constantly be looking inside the brain?
I think it would depend on the specific neurological or psychiatric disorder that you're talking about. I mean,
take depression, for example, or suicidal ideations that Mary Lou was talking about.
I mean, I'm envisioning, and you're going to have to inform me here. You're probably talking about functional images at that point.
Yeah,
structurally,
equivalent
changing
to fMRI.
Sure. So, I mean, again, I think ultimately one has to show that it actually does predict what you think it's going to predict, and that it has clinical utility. But I mean, the technology sounds amazing, and I mean, if that really works, it obviously could be revolutionary in our field.
You imagine, Mary Lou, people wearing these ski caps or a bandage, depending if they're looking at a different part of the body, to continuously be getting an MRI, and then transmitting it to doctors or medical people to be reviewing, or?
Sure, but I think for me the real moonshot is to transcend language and communicate with thought itself and hook our minds directly to computers so that we're all sort of Stephen Hawking in this way, that we're limited on the output of our brain by the mechanical motion of our mouths or our hands or drawing. And I think in images, and a lot of people do, and if you could just dump the image out that you're thinking, or the music out, or the words if you're a stroke victim, or all kinds of things. So I think that, sure, continuous monitoring makes sense in some cases, and in other cases, maybe it's, I feel weird, do I have internal bleeding after a surgery? And you just, put a bandage on, or, do you have a small tumor? Do you have something anomalous? Or look where in the case of looking for the blood signal, where the blood isn't. Do you have a clogged artery, a clogged heart? And can you pick that out and then call your doctor and, get...
The idea of the patients being in charge, more autonomy, I think is definitely a movement, and probably an important one. And I will say, because we're already out of time, that I've read about your work, and you've also talked about the idea of being able to predict thoughts in human beings using this technology, and even maybe predicting thoughts in animals, or understanding better what animals have to say as well.